Good morning, everybody, and thank you for joining for the first action period call for understanding healthcare disparities and health equity in atopic dermatitis patients, building knowledge, confidence, and change in primary care providers. This is the second wave of this program, but the first action period call for this wave. Welcome. Okay, for the agenda this morning, I want to welcome all of you. I put a message in the chat this morning for the things that we are asking to hear from you, your name, your practice, and something you've learned so far. I will review that in a little bit also. But we are going to start with Dr. Treadwell this morning. She will go over an overview of eczema forms, and then we will hear about eczema management from Dr. Fernandez-Faith. And then operationalizing in the primary care office and resources from Dr. Peltier. And then a brief look at the data that has come in so far from Zainab, some reminders on the program, and Q&A when we have time. Okay, so again, welcome everybody. In the chat, if you could please share the names of the providers on the call. Some of you are representing your practice. Some of you can bring in your whole team for the calls. We would just like to see who's on the call this morning, your practice name, and if you could please share something new that you have learned so far going through all the pre-work and talking to our providers so far, and maybe something from the kickoff. So we would like to hear that from you. But Dr. Treadwell, I have your slides and we can start with you.
Okay, good morning. Thank you so much. If you can go to the next slide, if you could, please. All right, it has come up that there have been questions about our terminology, about using the terms atopic dermatitis and eczema. I'd like to talk a little bit about eczema is considered the more comprehensive term. I think in the literature, you've gotten some information about the National Eczema Association. And so eczema is the comprehensive term, and atopic dermatitis is the most common form of eczema. And so sometimes we will use these terms interchangeably. There are other forms of eczema, dyshydrotic eczema, numular eczema, and papular eczema, which I'll try to talk about a little bit today. Next slide, please. So atopic dermatitis, as I mentioned, is the most common form of eczema. And many of you may be familiar with using the term atopic dermatitis as a term that kind of indicates a little bit of the allergies or asthma that might be associated with it. Eczema, again, is the comprehensive term. And so you'll actually see me using these interchangeably. Atopic dermatitis or eczema is the most common form of eczema. Mostly you'll see what we call eczematous patches, which I'll show you some examples of. There's erythema and scale, and as you've already learned, the erythema may be more difficult to see in skin of color. I'm going to also show you an example of white dermographism, which can help you in the diagnosis. Next slide, please. So here's a patient here in the antecubital fossa. This is sort of the typical eczema / atopic dermatitis that we see. A little bit of redness, some scale, and this is a very typical area where this can be seen. Next slide, please. On this slide, you'll see, in addition to the what's seen in the antecubital fossa, is also there are some eczematous patches that are also on the trunk. Next slide, please. So this is the white dermographism. What I've done is take the non-writing part of a pen and stroke the skin in a tic-tac-toe sort of morphology, as it were. And instead of turning red, which you'll see with red dermographism, it actually turns white or more hypopigmented when you do this. And so you're able to use this as an additional factor in terms of making the diagnosis of eczema. Next slide, please. Itching is a very significant symptom, and my next slide shows what typically happens. So you ask the parents to remove the clothing, and the gown, as you see, is over to the side. The child has taken that off too, and is just digging at the skin in the office. You can also see the eczematous patch there in the popliteal fossa. And so that's one of the things you see is this scratching that the patient is doing. Next slide, please. I'm going to mention papular eczema, and some of the slides you may be familiar with and may have seen. Again, we call these eczematous papules, and sometimes the distribution is very similar to what we see with usual eczema. Next slide, please. So here on the elbow, there are papules. The redness isn't easily appreciated here. Some crusting and some erosion due to the fact that this child has been scratching at these lesions themselves. Next slide, please. Here on the trunk, again, papular eczema. So there are eczematous papules. They're here on the trunk, similar to what we saw with the patches. And then the next slide will show you in skin of color how these may look a little bit hyperpigmented. Next slide, please. Numular eczema. This refers to coin-shaped lesions. Generally, they're less itchy. There is an increased incidence of secondary bacterial infection. Many of you already are aware that about 75% of all patients with eczema may be colonized with staph. In some cases, there is more frank infection, which I'll show you on the next slide. And the differential is tinea corporis. Next slide, please. So here's a patient who has numular eczema. These are round lesions. This is a pretty significant case of that. They're round lesions, they have scale, and on the next slide, we have a close-up. And here's more of the honey-colored crust that you typically see with impetigo. This is different from tinea corporis. I mentioned that it's in the differential, but one of the things, tinea corporis tends to have a very distinct border. So you'll see the tinea corporis lesion and then normal skin. And with numular eczema, you actually see this sort of distribution where there are more lesions, and they blend into the surrounding skin, where you see more scale, more erythema, rather than what you might typically see with tinea corporis. Next slide, please. Pityriasis alba. This is often noted in early spring. These are hypopigmented macules and patches with just a little bit of scale. Next slide, please. Again, this patient may look familiar, but in the spring, when the surrounding skin starts to become darker, then these macules and patches may become apparent. And what you'll see is, as in this patient here on the cheek, these hypopigmented areas. You don't see much erythema, even if they're, even in Caucasian skin, you may not see much erythema, but you'll see this hypopigmentation. They're irregular and maybe a little bit of scale associated with it. Next slide, please. Dyshydrotic eczema, I think we haven't mentioned in this forum, but there are vesicular, and this should be papular. It auto-corrected when I put papular lesions of the size of the finger. They're very itchy, and so often in the differential, these have been diagnosed as scabies, but the lesions will be confined to the fingers, sides of the fingers, and the hands. Also in the differential is bullous impetigo and allergic contact dermatitis. So next slide, please. So here's a patient with this hydrotic eczema. They tend to be a little bit older, but I have seen it in some elementary school patients. They complain of itching, they've been scratching, there may be some crusted areas. Next slide, please. There are some bullous or vesicular lesions on the sides of the fingers, which is typically where you see dyshydrotic eczema. Next slide, please. Okay, I think we have a little time for some questions. There may have been some in the chat, but I couldn't read them and do both things at the same time. But Brooke, if you'll let me know what I might need to answer, please.
Sure. Yes. Right now, feel free for the participants to put your questions in chat or to unmute and ask Dr. Treadwell directly. If you think of anything later, you can always email me. Nothing in the chat so far, Dr. Treadwell.
Oh, okay.
Hi, Dr. Treadwell. I was going to ask for the white dermographism. Do you do that on just like their normal skin, or are there patches where they have eczema?
You can do it on both. Usually I do it on normal skin because I'm trying not to irritate eczematous patch. But so you can do it on normal skin, and that it'll be within a couple of minutes. Then you can see that hypopigmented change versus red dermographism, which some children may have.
I waited the 7 seconds. Any other questions for Dr. Treadwell right now? That was really good information. Maybe Dr. Treadwell, going into or in winter and dry skin conditions, anything else to think about in terms of what our doctors will see in their office?
Certainly with patients who have eczema, there'll be more dry skin. And I think Esteban is going to talk a little about moisturizing, which is very important. Moisturizing both for the barrier function and for the fact that the dry skin itself will itch. And so often we see kind of dry skin all over and eczematous patches in certain places. And the emollients are very important. I'll say that ahead of time. I know Esteban is going to talk about that.
Thank you.
Oh, I do have one more question.
Okay.
When you're worried about like a secondary infection and you're getting like a wound culture swab, I've had a couple patients where like they don't really have any open lesions, like everything's crusted over quite a bit. And like one came back positive, but then the other one didn't grow anything. Do you think it was just because it wasn't an open lesion, or do you think like if it was a negative culture, then we should stop antibiotics?
That's a great question. If they're crusted over, you're less likely to get a positive culture. On the patient that I showed with numular eczema, that was had some weeping and some crusting. And I would try to get the culture from the weeping area versus the crusted area. You can, since 75% of the patients with eczema will be colonized with staph, you don't necessarily have to get a culture. The cultures are helpful if it's like methicillin resistant staph. Certainly if I see a patient with eczema herpeticum with herpes infection, I will do that to document that there's an infection there. But generally, again, I think I don't want to take Esteban's words out of his mouth. He'll talk to you about treating some of the bacterial secondary infection for the patients. But you don't always have to get a culture, since 75% will be colonized.
Thanks.
Pat, I'll ask you a question. Do you
Okay.
see, so in, if you have in terms of different types of eczema, do you, if a patient has either numular eczema or papular eczema, are they at risk for other forms of eczema, or typically if they have numular eczema, is that pretty much how they're always going to present?
Not necessarily. That's another great question. And I have a slide, which I didn't include this morning, that has a patient with a patch of eczema and then papular eczema near it. And so each patient, as I think anybody on this call is aware, they have their own patterns. And so you can see both in the same patient.
Well, seeing that slide on future calls will be something we will look forward to, Dr. Treadwell.
Okay, no problem.
Okay. Anything else for Dr. Treadwell? Okay, hearing none, Dr. Treadwell, I appreciate your time, and we will go forward on to eczema management with Dr. Fernandez-Faith. Dr. Faith, I have your slides.
Okay, thank you very much. Thank you, Pat. That was great. Let's go to the next one. So we'll spend the next few minutes talking about eczema management. So whenever we talk about or think about how do we treat eczema, I always think of two main things or two main points that we have to tackle. One is the skin barrier. We know that patients with eczema have a defective skin barrier. Their skin is not a perfect barrier, and we have to try to repair it as much as possible. And of course, we have to treat the inflammation, and the inflammation is what's causing the redness, a lot of the scaliness, the itchiness. It's causing the rash. So we really need to tackle both at the same time. Next one. So for the skin barrier, the most important thing, as Dr. Treadwell was mentioning, was use the moisturizer. So moisturizer, moisturizer, moisturizer. And here, we really don't have to get very fancy. Something very simple, something that is fragrance-free. The formulation is going to be very, very important to consider. So in general, we want to use either an ointment or a cream. An ointment is going to be kind of greasy like Vaseline. A cream is going to be more like a white cream. Here, we really have to take into consideration some cultural preferences. There's some cultural groups that will prefer one type of formulation versus the other. Some will really prefer an ointment versus a cream. In general, an ointment is a better moisturizer, but at the same time, it's greasy, may not feel great. So we have to consider the preference of the patient and the parents. The vast majority of moisturizers are over the counter, and we often give them a list of the ones that we recommend. So they very simple ones like Vaseline, again, Aquaphor, CeraVe, Cetaphil. Those are really good moisturizers to recommend. Another important part here is that our recommendation for a moisturizer may change during the year. So as Dr. Treadwell mentioned, the winter time, it gets really cold and dry. So here, during this time of the year, we want to use the thicker type of moisturizer, so maybe the ointments. But during the summertime, it gets muggy and sticky, so they may not want to use an ointment. Maybe they want to switch to a cream, something that is a little bit lighter. Here, I think also the age of the patient is very important. Most teenagers are not gonna love going to school looking and feeling really greasy, so we have to take that into consideration as well. Sometimes what I would recommend, if they don't like that greasiness, but they kind of prefer it on their skin, what I would recommend is, well, use the cream during the day and then use an ointment at bedtime. So they can use a little bit of both, use the greasier one at night when they're not going to go out of the house and be out in public, and they can use the cream that is a little bit less noticeable during the day. So that's another thing that we can recommend. As far as baths, so baths and showers, that's something that has kind of changed throughout the years. In the past, we used to recommend very infrequent baths and showers, but that has really changed, and our knowledge on what the effect of baths on the skin is has changed. So now we do recommend more frequent baths, even daily, or sometimes more than that. But the baths really need to be very short, less than 10 minutes with lukewarm water. Use a fragrance-free cleanser for the babies and the little ones. I'll often tell the parent, you don't have to use soap all over the body, maybe just in the diaper area or any other areas that are visibly dirty, but you don't have to use soap on the entire skin necessarily. And then, of course, pat dry. And what's really, really important, and one of the reasons why frequent baths are helpful, is for the application of the moisturizer right after the bath. And that will really help to seal in some of that moisture into the skin. Here, there's also, I find there's a lot of cultural variations. Some cultures are very used to doing very frequent baths, sometimes even more than once a day, even twice, 3 times a day, while others are not. And sometimes parents will take that that recommendation of frequent baths not very well. So it's important to to meet them where they're at, and maybe find a compromise. Say, well, let's start with every other day, and then we can go from there. And parents will often find that, oh yeah, you're right, the more frequent baths is very helpful, let's do it more frequently. Also, the bathing is very soothing, especially for babies, and their itchiness goes down, they become more calm, and so that's another way that will help with their symptoms as well. Next one. And then the other big part that we need to treat is the inflammation that is causing the eczema. And here, the standard of care are topical corticosteroids, of course. There are some topical non-steroid options, tacrolimus, pimecrolimus, and some newer ones like crisaborole, and the newest one is ruxolitinib. These are all topical medications, do not have a steroid. We use this in more specific cases or more specific locations. So for example, if a patient has eczema on the eyelid, so they have periocular eczema very consistently, and this is an area where we may not want to use a topical corticosteroid for long term. So this is when one of these non-steroid options would be a really good place to go. But in general, we really want to rely on the topical corticosteroids that we have available to treat the eczema inflammation. Next one. So when it comes to topical steroids, there's a lot of factors that we have to take into consideration. So we have to decide on what potency we're going to use, low, mid, or high potency. Again, here, same as with moisturizers, we want to decide what formulation, what's the vehicle that we're going to prescribe. Is it an ointment, a cream, a lotion, a solution, an oil, a gel? There's a lot of different formulations that we can choose from. And very, very importantly, I'll talk about this in a couple of minutes, is the formulation size. Now, we have to consider the age of the patient. It's not the same if we're treating a young infant versus a teenager. What are the areas that are affected? Is it mostly thinner skin, like the face, neck, armpits, or groin? So this is much more sensitive areas where we really want to stick to the low potency medications, versus thicker spots, the trunk, the extremities. Is it this hydrotic eczema? Is it mostly on the hands and feet? So here we want to go more in the mid to high potency type of topical medications. And of course, the eczema severity. And so because we have to consider a lot of different factors, it is very difficult to give like one recipe that will work for everyone, or to come up with a really good algorithm that we'll just follow and that will help us pick the right corticosteroid. So this is a little bit of the art of medicine in trying to pick the one that's right for your patient. Let's go to the next one. So this is a partial list of the topical corticosteroids in potency. So there are 7 classes, 1 through 7. 7 is the lowest potency, and 1 is the highest potency. And again, this is only partial. There's a lot more topical corticosteroids. I just included here the more common ones, the more popular ones that we tend to use. Now, you might see, if you look at a different source, at a different table of topical corticosteroids, you may find some differences. One medication might be 1 class over, 1 class down. But in general, this is what we would consider super high potency, high, medium, and low potency. An important point to consider here is, next slide, the formulation that I mentioned before. So take a look, for example, at triamcinolone acetonide 0.1%. So if you prescribe a cream, that's going to be a class 4, or it's a medium potency. But if you go to an ointment, same medication, same concentration, but an ointment formulation, you go up in potency by one class. So that would become a high potency topical medication. So sometimes if we change the formulation, we are changing the potency as well. In general, if we go from cream to ointment, the ointment is going to be more potent, but it doesn't always apply. So it's important to look at the table and see if there's any changes. So for example, if you look at desonide, ointment, cream, lotion, whichever formulation, is the same low class potency. So be mindful of the type of formulation that you are prescribing. Next slide. And as a starting point, something that we can do is use the low potency class 6 and 7 if we're treating sensitive skin areas. So the face, the neck, the groin. If we are treating more trunk and extremities, we can definitely go up in potency, maybe a 4 or 5. We could start to go into class 3, especially if we're treating hands and feet. Hands and feet can be really, really tricky to treat. They need much stronger topical steroids. But I think these are good kind of starting points on where to go with your patients. Here also we have to take into consideration the patient's age. So if we're treating an infant, we really want to stick to maybe the lower potency versus a teenager. Then we have more leeway on using the higher potency type of medications. Next slide. And again, this is just to show you kind of what are the differences in the formulation, both the vehicle, but also the formulation of the moisturizer. So it depends. So basically, we divide it in ointment, cream, lotion, and gel, and really based on the percentage of oil that it has. And so the one that has the highest concentration of oil is going to be the ointment. That is going to be the greasiest one, and then that's followed by the cream, then the gel and the lotion. I'm sorry, and then the gel. Next slide. In general, for eczema, I like to use ointments if possible. Ointments are going to feel better on the skin. The creams would be my second choice. Sometimes the creams can have a burning effect on the skin, especially if the skin is very, very irritated, if they have a really bad flare. But here, I always ask the patient or the parents, we can give it to you as an ointment, or we can give it to you as a cream. These are the differences. Which one do you think you would prefer? No matter what, if I think that the ointments are going to work better, if they're not going to use it, it's not going to work. And so it's very, very important to take this into consideration, to really ask them, these are the differences. The ointment is going to feel better. It's not going to burn. But if you prefer to use a cream, we can give you a cream. And so it's very, very important to take that into consideration, because obviously the creams only work when they are applied and not when they stay in the tube. Next one. The other important point is the formulation side. So very often I will see patients who come in with a really good plan from their primary care doctor. They come in with the right potency of the medication. They come with the right formulation, the right vehicle, but they come in with a very, very, very small tube size. Next slide. So this is a patient that I saw very, very recently. He's a 5-month-old boy with pretty generalized atopic dermatitis. He has it pretty much head to toe. And he was given Desonite as a starting point, Desonite 0.05 ointment, which is a great option. But he was given a 15-gram tube, and that's only going to last him a couple of days. And so what happens is parents they go home and they get the medication, they start to use it, things are getting better, but then they run out of the medication and they are stuck. They cannot do anything else. They cannot go back and get a refill because they have to wait 30 days to get the next refill. And so they're really stuck. Next slide. So how do you know how much to give? So a unit that you could refer to is the fingertip unit. And so this is the fingertip of an adult. And 1 fingertip unit equals to 0.5 grams. Next slide. And so this slide shows you roughly how much an adult is going to need to cover a specific area. So for example, the face and neck, in an adult, you will need a 15-gram tubes to treat 10 days. And obviously with larger areas, you're going to need a little bit more. But what about kids? Next slide. And this slide shows you roughly, depending on the age, of course, you're going to need different amounts of the medication for the patient. Now, here, I don't want you to go, I don't expect anyone to be calculating how many fingertip units you're going to need and make calculations to decide how big of a tube you're gonna give them. But I think what's important is to get a sense of roughly how, depending on the area that you're treating and how bad it is, how long do you think they're gonna need to treat, to be very mindful of how much you are giving the patient. Next slide. And so coming back to the patient that I showed you, so he was given initially a 15-gram tube. But if we go by that very kind of strict rule of the FTUs, he's actually going to need 60-gram tubes to treat for about 2 weeks. So we need to give him 4 times more of what he was given before. It was the right medication, the right formulation, the right potency, but they just didn't have enough. So this is a very, very important and kind of more practical point to give you so that we can treat these patients better. Next slide. Now, how about systemic steroids? And this is where we take a little bit of a pause, we gasp a little bit. I think what's important here is that to understand that systemic steroids is not a good way to treat eczema long term. It's really they're not safe enough. They have potentially too many potential side effects. So it's not a good chronic long-term treatment. Do we use systemic corticosteroids? I would say yes, occasionally, very occasionally. Most of the time, I'm using systemic steroids in patients with eczema, typically if I'm bridging to a systemic medication. Let's say I'm going to start there. It's so bad that I'm going to start them on methotrexate, or I'm going to start it on dupilumab. And so because they have such a bad flare, I'm starting them on systemic corticosteroids, knowing that they're going to be on a different systemic medication afterwards. The problem with systemic corticosteroids, I think it's two main problems. One, the eczema gets better very quickly, and parents love it. And so they're going to be asking for more, which is, again, not the safest thing, not the best thing to do for the patient. The other problem is that it gets better so quickly that parents then take a break from all the topical medications. And when they're done with the systemic corticosteroids, the eczema comes back, and sometimes it comes back with a vengeance. So some patients do get what's called a rebound flare, meaning that the flare is much worse than the initial presentation that they have. So systemic corticosteroids are used very occasionally in very kind of select cases. In my practice, again, I use it mostly for patients that I'm going to transition on to a different systemic medication to control their eczema a little bit better. Next slide. Now, the other important part is how do we treat the itchiness? Dr. Treadwell was mentioning how itchy patients can be. This is a huge, huge component of their quality of life. Eczema is miserable. They're itchy, itchy, itchy all the time. Next slide. And here, what's important is to understand where the itchiness is coming from. So the itchiness is coming from the eczema. It is coming from the inflammation. So our goal, and what we really need to explain to the parents, is that the most important part is to get their eczema under control. Once we get their eczema under control, their itchiness is going to get better. We've been using antihistamines, oral antihistamines, for a long, long time. And the more we understand about eczema and itchiness, really, we've understood that the role of antihistamines in eczema is pretty limited. I will often use non-sedating antihistamines like cetirizine or zyrtec, particularly if the patient has other atopic conditions. So if they have seasonal allergies, allergic rhinitis, allergic conjunctivitis, because those antihistamines are going to help with those symptoms. Often they're already on that. It occasionally helps a little bit with the itchiness. But the sedating ones like diphenhydramine or hydroxyzine, those are really gonna have a very, very limited role. And we've come to understand that their role in treating eczema and treating the itchiness is it's really not that great. So we really need to try to minimize the use of these medications. I will occasionally have them use Benadryl or hydroxyzine, really just to give them a break, a quick break. If they're having a really bad flare of their eczema, they're not sleeping, nobody's sleeping in the house, maybe I will recommend doing a couple of nights of Benadryl or hydroxyzine. But really the goal is just to knock them out, to make them go to sleep. And that's why it's not a good long-term type of treatment. So we really want to minimize the amount of sedating antihistamines that we're giving these patients. We also don't want to give the parents the idea that by taking this oral medication, we are fixing the eczema, because the antihistamines are, if anything, they're just a Band-Aid, a pretty lousy Band-Aid. And so we don't want to give the expectation that an oral medication, which is actually a little bit easier to give as opposed to applying the topicals all over the body, is going to be the way to treat it. Next slide. And the other one that you'll find in the action plan is the use of bleach baths. So Dr. Treadwell was mentioning, and there was a question about treating infections. So I will often recommend you doing dilute bleach baths, particularly patients who tend to have repeated infections. If you have a patient that, I've already gave them an oral antibiotic 2 months ago. Now they're coming again with another infection, and then they come in a couple months with another infection. These are the patients that I think benefit the most from doing dilute bleach baths. There's not great evidence to show that patients who do not get super infections benefit that much, but in my experience, they can as well. But particularly patients who do get multiple infections. Now, in the action plan, you'll see that bleach baths are mentioned mostly in the red zone when they're really bad. Something to take into consideration here is that when they're flaring really, really bad, they have a lot of open sores. They may not love a bleach bath. And so what I recommend is to let's cool down the skin a little bit. Once the skin is a little bit better, then start the bleach baths. But don't start it when their skin is very irritated, it's open. They're going to hate it, and they're not going to use this again. And I do find it to be a helpful tool. Next slide. I think this is it for my part. Yep. Any questions now, or if we have time later, I'll stay until the end.
Thank you, Dr. Fernandez-Faith, for that good information. Feel free to unmute or put your questions in the chat. One of the benefits of this program is having the ear of our medical experts. So you're welcome to ask any questions that you have.
Good morning. This is Dr. Beto. I have a quick question. So regarding the bleach baths, is it possible that some patients will react to the bleach baths? Because I know sometimes when I have patients who flare up in the summer, sometimes I figure it might be the chlorine in the swimming pool that they are reacting to.
That's a great question. So most of the time, no, unless they're putting a lot of bleach. If they think that their skin gets a little bit drier or that they flare up more with the bleach baths, then I will tell them to dilute it even more and just put just a little bit of bleach. In general, most of our patients, and we can convince them, or we can tell them they get convinced to use the bleach baths. Mostly in the summertime, when they say that, oh yeah, whenever they go to the pool, they get a little bit better. When they go to the pool and they flare up more, often what happens there is that they get out of the pool and they don't rinse off the chlorine off the skin. And so when I hear that, what I tell them is the most important thing is once you get out of the pool, rinse off the chlorine, put the moisturizer on. If they get out of the pool and don't rinse it off, just let it dry on your skin, all of our skin is going to get dry. A patient with eczema is going to get drier and more irritated. So that might be the issue that your patients are experiencing.
Okay, thank you.
Dr. Fernandez-Faith, any best practices you can share about writing prescriptions? We talked about maybe formulation and size of the tube of the cream to make sure they have enough, but any tricks here? Instead of writing cover infected area, are you more specific on the prescriptions?
Yes. So for the prescription, so often with eczema, because we have kids who have more than one area involved. So they may have a little bit on the face and neck, then they have a little bit on the trunk or the extremities. So we have to often write a couple of prescriptions, sometimes 3 or more, which really makes it very complicated. So something that's very important to keep in mind is to try to keep it as simple as possible. If you can minimize the number of prescriptions, that is going to be a lot better. It's going to be a lot more simple for the parents to follow. Eczema treatment is a lot of work, and we can make it very, very complicated. So we really have to, take a step back, put ourselves in the parents' shoes, and say, okay, how can we make this as simple as possible? And it's very important to clarify in the prescription which medication goes where, which one is for sensitive areas, which one is for non-sensitive areas as well.
Thank you.
Okay, I have another question. This is Dr. Obeto again. So sometimes my patients will come in and say when they use the setting cream like Eucerin or CeraVe, their skin burns. So in that case, do you just change the formulation or?
Correct. And so often the issue there is a formulation. So that will happen more with the lighter or the thinner moisturizer. So the lotions particularly. Creams, not as much, but I do get it sometimes that when they use a cream, they will get some burning effect. So that is a formulation type. So a couple of things to do would be to have them use a thicker moisturizer, more of an ointment, Aquaphor, Vaseline. There are other ones that can be used. If they don't love the greasiness, what I will tell them to do is to mix them up. So mix the cream with a little bit of the ointment. So that will take care of the burning effect, but it would still not feel as greasy. For eczema in general, we want to try to stay away from the lotions. The lotions are just not going to be as moisturizing as creams or ointments. Now, they might like it for the summertime, but in the fall, winter time, they're typically not going to be enough, and it's much more likely to get that burning effect. That's a great question. And I will often recommend that even with the medication. Let's say they prefer a cream, they don't want to use an ointment, but the cream burns. And I tell, okay, mix it up with a little bit of the moisturizer, or mix it up with a little bit of Vaseline or Aquaphor, so you get rid of that burning sensation.
Okay. One more question. So I know sometimes when I prescribe CeraVe, there's an alert that comes up and says this patient is allergic to eggs. Eggs, like something about eggs, like I guess CeraVe has eggs in it. So
Interesting.
if they're allergic to eggs, there's an alert that comes up and says this patient has an egg allergy. Are you sure you want to prescribe it?
That's a great question. I honestly have not heard that. I would have to look into that. I am not aware that CeraVe has any egg ingredients, but I'll have to check. Yeah, I've actually not encountered that in the past. I'm not aware that it has any egg components, but that's a great question. Let me check on that.
Okay.
Dr. Fick, do you often recommend the wet skin wraps too?
That's a great question. So the wet wraps are going to be very, very helpful, especially for patients who have really bad flares. So the wet wraps, what that means is we get their skin wet, then we put a layer of their topical medication, then we put a layer of the moisturizer, usually more on the thicker side, and then we do a layer of a wet layer. So for example, in little ones, we'll recommend doing like wet pajamas. So they get a pair of wet pajamas on, cotton pajamas on, and then a pair of dry pajamas on. And they leave it on for as long as they can. The little ones may not like it for too long. So even if they can leave it on for an hour or so, that is great. And then they take everything off. And they put their regular pajamas on. It's a lot of work. So you really need to have a very, a family that's willing to do it. And I don't recommend doing it every single day, but maybe it's something that they can do 3 nights a week. And that will basically, the goal is to make the medication penetrate better into the skin so that it gets the flares under control. Sometimes when parents, when it works, they love it and they continue to use it. You could even do it without the topical corticosteroid, just with the moisturizer, and it'll penetrate better and it will moisturize the skin a lot better. For patients who have much more limited areas, say for example, it's only in the hands and the arms or the feet and the legs, then you can use long tube socks. Just makes it a little bit easier. You don't have to cover the entire body with pajamas or with what have you. But long tube socks can be very helpful for more localized areas.
Thank you.
Yeah, and I believe the action plan has QR codes that will link you to the bleach baths and the wet wraps.
That's correct. The updated version does have that. Dr. Peltier will cover that. Yes. Any other questions for now? We will have time at the end if you think of anything additional too. Okay. Hearing none. Dr. Peltier, I have your slides.
Great. Thanks, Brooke. And thanks to Pat and Esteban again for just a fantastic, we sort of said you need to talk about diagnosis and treatment, and we're going to give you about 20 minutes each. So just great information. And again, that's as Brooke said, that's the nice thing about participating in this program is that you sort of have, every other month access to pediatric dermatologists. So, keep your questions coming in. I'm just going to very briefly, I think most of you have seen almost all of these slides that Brooke and I recorded for sort of the pre-work kickoff webinar, but we just thought it would be good to just kind of, again, while we're face-to-face sort of virtually and give people a chance to answer questions, to kind of go over how you operationalize all of this and just go over some of the resources that the chapter has created, both from our previous webinar or from our previous wave, and that we've tweaked for this wave. So in full disclosure, I participated. I was the medical director for wave 1 as well, but actually my practice participated in this. So I just kind of wanted to share some of the things that we did that you may find helpful and useful as you're trying to figure out how to actually make this QI project work for your practice. Next slide, Brooke. So one of the very first things that we did, although we had sort of a generic rash protocol in our EMR, and we use PCC, Physicians Computer Company. We do not use Epic. For those of you that are on Epic, one of the really neat things from the last wave was that some of the practices and participants were sharing their Epic protocols with each other. So I think that was really neat. These were really just some of the things that we, as we were developing a atopic dermatitis specific EMR protocol, things that we deliberately and intentionally put. So in the history section, when did the rash first appear? Where did it originally appear, and what did it look like? How has it changed over time? What treatments, both topical and potentially other oral treatments, were tried, and what were the results? And then these are, as you'll see in a minute, these next set of symptoms were taken directly from the data capture tool, which really helped when you're trying to capture and report data for the QI project. Is there pruritus? Is there pain, dryness, swelling, sleep difficulties, behavioral or emotional problems? And then was there a previous history of atopic dermatitis? Next slide, Brooke. And then really trying to sort of hone in as much detail as possible when you're documenting your physical exam. Is there erythema present? And we sort of had these classifiers, right? Barely, slightly, clearly, markedly perceptible. Was there induration or papulation? Was there lichenification or papulation? And then was there oozing or crusting? And then in order to capture, the way we ran our reports is we did diagnosis reports. So atopic dermatitis was the only choice on there. Now, obviously, there may be a secondary diagnosis if you have, either a bacterial superinfection or potentially eczema herpeticum. But that way we made sure to capture that. So when we were running our reports, we were able to pull that data. We did have a marker to sort of make you decide what was the severity. Was it clear, almost clear, mild, moderate, severe? We put a order in there for the quality of life index, which I'm going to show you in a second. And then all of the things that Esteban just went over, we put in the plan specifically where our providers could check box and then add some specifics, right? What was the moisturizer routine? What topical steroids, or if there was a steroid sparing agent, were used? Did you complete an eczema action plan? And did you provide educational handouts to the families? And again, you are more than welcome to use, we've developed some rec cards that we've tweaked for wave 2, but you also, if you have some AD handouts that you've been using for years and they work for you, that's okay too. The other thing I would encourage you is, if your EMR will allow, and I think Esteban would agree with this, right? Pictures are worth 1,000 words, right? So if you can take a picture of that rash, that patient's atopic dermatitis, and upload it into your EMR, I think that's going to be very helpful over time. Next slide, Brooke. So again, this is the provider data tool that as you begin to each month collect your data that you will be sort of reporting and using. And as you can see, a lot of the sort of anchors were incorporated into that atopic dermatitis protocol. So it made it very easy. I was the one that actually did the data collection and reporting, and it was very easy for me. Obviously, the biggest thing we tweaked this time as we're focusing on diversity is we included race of patient as well. And then also insurance carrier, because again, we're using private versus public insurance as a marker of diversity and social determinants of health. Next slide. And again, this is just more detail on the atopic dermatitis collection tool, which you guys will have lots of experience with each month as you're entering your data. Next slide. I just wanted to briefly go over the eczema action plan. Again, you've seen this, you will have access to this. And the biggest thing that we've changed is we've added some QR codes for some of the bleach baths and other things. Next slide, Brooke. So this is what it looks like overall. You have the green, yellow, red zone, very similar to an asthma action plan, which is sort of how we, the model that we used when we created this for wave 1. Next slide. And I'm not going to go into detail again, but just sort of green zone, where really, that's really your maintenance zone, where, as Esteban said, really you're going to make sure you want to educate your families to continue that regular use of moisturizers and regular short lukewarm baths. Next slide. Yellow zone. Things are some active inflammation, but yet manageable, and that's really when you're going to be starting to have them use their rescue medicines, those topical steroids that Esteban covered. Next slide. And then when things get really bad, right, red zone, this is really where you have a rescue plan for the treatment, and that may be increasing potency of topical steroids. It may be time to refer to a pediatric dermatologist. Next slide. I'm just going to briefly go over the quality of life screening tools. There are a couple of different ones. There is an infant one that's validated up to age 4. There is a child version for age 4 to 16, and there's both a cartoon and sort of a more prose version of that. And then there's a teenager version for 12 to 19. And there is the link. Again, we'll make sure that you get that, and you can download the appropriate quality of life scales. Next slide, Brooke. Just going to kind of show you, these are the questions. I'm not going to read all of these. This is some questions that the parents are asked in the Child Quality of Life Index over the past week. Next slide, Brooke. This is what the cartoon version looks like. So a little bit more kid friendly. Next slide. I just briefly wanted to mention some PDSA examples. One of the things that you're going to be doing as part of this QI project, any QI project is doing some PDSA cycles. Again, those are going to be very personalized to your practice and to the needs of your practice as you go through this project. These are some of the examples of the QI or the PDSA cycles that my practice did. The first one is very simply creating and using that AD specific EMR protocol. It was a little bit of a lift to get, number one, to create it, and then to get my partners to actually use it. So we created it, and then we found out they really weren't using it a whole lot. So that was our next PDSA, was to actually do some education to get our providers to actually use the protocol when they were seeing a patient with AD. And then our third PDSA cycle was really focusing on education and increased use of that quality of life survey. Next slide, Brooke. And then I just am going to end, and I'm happy to answer questions. I want to make sure we leave enough time for Zainab and other questions. But I really think, as in any QI project, right, communication and collaboration are key. You all are sort of the practice champions for your practice. So just, communicating with your providers, with your back office staff, as you're going throughout this project, I think is going to make a successful project. And we are here for collaboration and help at any time. And I will just kind of pause and see if anybody has any questions. I know I went over that pretty quickly.
Thank you, Dr. Peltier, for the review. Hopefully our participants have at least seen all the good resources that you shared. Everything is available on the program website, the one that you have to log into with the password. If you have been having any problems with that website or have any questions as to where things are, we can always have that discussion too. Okay, hearing none. Zainab, I saw you were on.
Mm-hmm. Yeah,
Okay.
Thank you, Brooke. And thank you, Doctors Fernandez and Peltier and Dr. Treadwell, for all the great information that you shared. I'm going to go over some of these data slides real quick. I know a lot of you have a busy schedule to get back to, so I can go right ahead into that first slide. And so this data is coming from the pre-work surveys that you physicians have completed. And so really what I wanted to show was the patient profiles of your practices. And so here we have two different demographics that we can talk about. So your patient racial and ethnic background, as well as your patient payer breakdown. The majority of the patients that visit your practices are white, followed by Black or African Americans, then Hispanics, Asians, and then other. And as we go through the data slides, you'll see that this pattern or this kind of breakdown is pretty consistent with the rest of the data that we're going to show. And then in terms of payer breakdown, it looks like the majority of the patients that that visit your practices have Medicaid as their primary health insurance, followed by a private insurance, either employer provided or private that the family provides. And then after that comes the self-pay or the uninsured individuals that visit your practice. And then TRICARE or the veterans insurance comes as the last one. I'm ready for the next slide. And so as I went through the data that you submitted in your pre-work survey, I just want to make a clear distinction by the number of patients that have an AD diagnosis or have AD symptoms by the practice. And then by the provider. So the provider could be working in different practices or could have patients that are outside of that specific practice. And so there's a distinction between the two here in this figure as well as in the text. And so by practice, it looks like there is some sort of AD symptom or diagnosis in 21% of the patients that visit the practice or the base population of the practice. And then by provider, it looks like about 16%. I'm sorry, that and the text is incorrect, but the graph is. So it looks like it's 16% by provider. So 16% of the patients that the provider sees have some sort of symptom of AD or eczema, or have some sort of rash or have an actual diagnosis. And so I'm ready for the next slide. And then here, we also wanted to ask some questions about whether or not the provider was referring the patient to specifically a dermatologist, is what we've seen most commonly, both in the answers and what we've seen historically. And so dermatologists, again, are the most commonly referred to physicians from that primary care practice. And most providers are referring either quarterly or monthly. So it doesn't look like the large majority of their patients are being referred to dermatologists. And that's, and as we move through the project, that's really what we want to see is we want to see that there are less referrals to dermatologists when it's not necessary, and more kind of confidence within the primary care physicians to kind of diagnose on their own, to kind of determine severity on their own. And then the most commonly provided resources to families are handouts, and I know that we're also providing some very good handouts, and then an eczema action plan. So those are the two main types of help that we're hoping that physicians and practices are providing. And so the baseline data, I just, want to make this clear before, we move further into the project. So this baseline data isn't a very direct comparison to what the data that you'll be collecting in the project is. So it's going to be a little bit difficult to kind of say, well, this is the way that we were doing it, or this is what the data has shown before. And then after the project, this is what we're looking at. So we're hoping to see within the project months to kind of see an increase in diagnosis or an increase in correct diagnosis, and a decrease in dermatology referrals. So we had about 355 screens that were submitted in baseline. And here you can see that actual number of screens per or by race. And you can see this figure kind of follows the same breakdown that we saw in the race for the patient profiles. And so the majority of the positive screens, or the majority of the patients that had AD or AD symptoms, were white, followed by Black, and then Hispanic, Asian, and then mixed race individuals that could be Black and white, or white and Asian, or anything like that. So the mixed race includes all of those. And again, here in the second bullet, you can see that the number of diagnoses or screens by race is consistent with the distribution of race within the different practices. And then really, if we wanted to look at the percentage of diagnosis among the different races, then we would need the total number of patients that you were seeing in your practice. So if that data is easily available for you to provide to us, that would be great. We could provide additional information on baseline. But if that's not a possibility, then that is okay as well. So if anyone has any questions about the data that they provided through baseline, or if they want us to look at their data and provide it to them individually and have a separate call about that, that's definitely a possibility. You can email Brooke and she can, and we can set up a time and some slides that would be beneficial for your practice. Or if you have any questions about data in general, then we can definitely answer that. Like Dr. Peltier said, you get access to us once every other month. So whether or not you have your questions prepared, please don't feel like you can't ask them during any of the other times because you totally can. But I think this is all I had prepared for today. And I know I went over that pretty quickly, but I think we're at the end of our meeting. So if anyone has any questions, please put them in the chat or go ahead and ask. But if you don't have any questions right now and remember that you have one later, please email us and let us know.
Yeah, Zainab, thanks so much. I just want to let everyone on the call know we are at time, but we will be diving deeper into your data on the practice coaching calls, which are going to occur every other month that an action period call doesn't occur. So action period calls are starting in January. So your first practice coaching call with Zainab and myself will be in February. So sorry that we are at time. I will leave 30 seconds for any last minute questions, or like everyone said, you can certainly email me and I will get you the answer. Okay, hearing none, I want to thank everybody for the good information shared today and for logging on to the call and participating. I will be in touch with you with further information, and have a good day. Thank you so much.